Thank you, Magnus. So there's a lot of questions in the title. I'm sure I'm not going to answer all these questions, but I'm trying to give you some data to date, and then you can get it with you in your luggages and go back home and have a reflection about the way to use the probiotics or not in your units. The first point, thanks, doesn't work. When we are looking at the probiotics, then we need to go to the literature and look at what are the benefits and the risks, and if you want to decide what we are going to do, and that's not the only point. We can see that there's countries in which the probiotics are available, and sometimes they are available for adults, not for infants, not for preterms. So it's not an easy thing to decide what you are going to do, but we have to look a little bit about the data. And when we look at that, you can just remember, because sometimes when you're talking about NEC, you have some people are saying to you, no more NEC in my unit. It's a little bit difficult to believe this, because NEC is a multifactorial disease, so it's quite difficult to have no more NEC. And when you look at the data, quite recent data, you can see that NEC is still devastating disease, and there is a significant incidence, especially in ELBW infants. There is a high mortality rate, as you can see, from 15 to 42%, and there is a poor outcome once surgery is required, and that's poor outcome at short-term and long-term outcome. And there is a special high cost for this pathology, so for this disease, so we have to be careful about that. And we know all that the best way to deal with this disease is to look at prevention. And when you look at the pathogenesis of NEC, then if you use probiotics, then you can act on both on the intestinal maturation and gut maturation, and on the other side on the composition of gut flora. So when you go back to the first randomized controlled trial, you can see that in the first, in the 2005, there was 2 data presented at the PAS meeting, and they showed the same thing. That means half the incidence of NEC. The first study from Bin Noon was going from 16% to a 4% incidence, and that means that in settings where the NEC incidence is high, it could be efficient to use this type of probiotics, which was Abecedophilus, which is a mixture of Bifido, Strepto, Thermophilus, and another Bifidobacteria. And more interesting, the study from Lin, which is going from 5% in the control group to 1%, and it has been coming after a lot of non-randomized control trials who have been showing also a half the incidence of NEC. So it was just confirming. And then when you are looking at the data 8 years later, what you can see, there is a few meta-analyses that have been performed. And the last one is, I collected the data from Girish Deshpande in the last PEACE meeting. So we have 33 high-quality randomized controlled trials, more than 4,000 babies. And then you find constantly the same effect of reduction in NEC. And more important, which is not always the case when we have some intervention in neonatology in the past years, a reduction of mortality, which is quite important, and it's quite an important effect. So when you look at that, you could say that we should go for probiotics. But when you look at the data precisely, then I took the meta-analysis from Alpha, the first one. As you can see, there is a lot of heterogeneity in the probiotic strains, Lactobacillus in 7 cases, Bifidobacteria in 4 cases, Saccharomyces boulardii, which has been shown to provoke some hepatic abscess, so it's not recommended. Mixtures of probiotics, postnatal age at beginning, which is not the same in all the studies. The duration of supplementation is not the same, and the main outcome criteria is not the same. So it's very difficult, and it's make difficult to have firm conclusion from the data of the meta-analysis. And then in the following years, you have these types of conclusions from famous authors like Joseph New, and Girish Deshpande was the first one who's been saying that given the totality of evidence, additional trials were not necessary if a suitable probiotic was available. And then there was a lot of people giving their opinion, which was not completely in agreement with that, because we understand that people just are wondering which probiotic I'm going to use. What about the benefits in the so-called modern preterm infants? Because they have more antenatal steroids, they are inborn, they have surfactant, they have human milk, more human milk. So is the risk the same? Is the probiotics, are they beneficial for the infants still in this case? What about the other potential benefits on late onset sepsis, digestive tolerance and growth? And what about the risk of sepsis? So you could explain that there is a lot of people that are hesitating, but in a lot of countries the probiotics are widely used, but it depends again what are the regulations in your country and what is authorized or not. When you look at the data from the meta-analysis from Berlin, from Gutmann, and in the group of Bureau, and then it was a very interesting thing that they show that they found that the probiotic use was associated with a reduction of NEC, even when trials were in settings where the mortality rate was low when compared to the high mortality rate. Even if the NEC incidence, baseline NEC incidence, was low when compared to the high incidence settings. The same for studies where there were a lot of ELBW or predominantly breastfed infants. So it seems that even in the so-called modern preterm infants, it could be quite efficient. But when you look at the interesting analysis was done by Tommy Hatch, and just look at what happens depending on the strains, showing that from his critical review in 2012, that when you look at bifidolactis and LGG, lactobacillus GG, then you have a wide number of infants, and then you can see that there is no real effect when you're looking specifically on the strain. That's still a remaining question, and that the same for deaths. And then a quite interesting meta-analysis from Wong has been published recently, and it was included only the RCTs from Europe and also 5 or 6 RCTs from China. And so there are more infants, and then they found not exactly the same, but it's just species, Bifidobacteria against lactobacillus, and they found that there was an effect of these different species and both the species together when they are looking at the NEC. It was not completely the same for the deaths. So there is still discrepancies about the effect of strains, and the analysis from Gutmann went to an interesting point, is that when he looked at that, the efficacy on NEC, he found that the efficacy, the association of 2 probiotic species was somewhere more efficient than a single strain. And that was confirming the results from in vitro and animal studies. This one is one of these studies, showing that when you're using monostrain probiotics, you have a less efficacy when you're using multi-strain probiotics on the same species, and you have less efficacy when you're using multi-species probiotics, which could be logical because you are probably combining the strain's properties, and then you enhance the chance of survival and colonization by the probiotic strains. However, it's not yet the end of the road, because we still need data to refine the therapeutic regimen, because we don't know exactly which is the best strain or mixture of strains. When you look at the literature, these 2 are available in the market in some countries, and these are the 2 ones, to my knowledge, which has been the more evaluated in RCTs. And you can see that for these 2 RCTs, the reduction of NEC and mortality was obtained with this type of products. And the other one, it has been used in the Bin-Nun study, and the other one is coming. First results have been shown in the PRS meeting in Washington this year. Is PRETERM study, and I think there is another one study which is coming from England, but I don't have the results. So we also have to work on the way to give the best way to give it to the infants, the dosage. And then we have still some remaining question about safety and other beneficial health effects. And we can have a look at infections, because it's an interesting point, and then we would like to know whether it could reduce the incidence of infection, and if there is some infection coming from the probiotic strains. And when you look at the adult data, what we can see is an interesting report There is some case reports of bacterial infections with probiotic strains, but there is a recent analysis of a few RCTs in adults, and as you can see, what is shown is that in the group, it was high-risk patients, post-operative high-risk patients, and there was always a reduction of the incidence of infection in the probiotic group, not the opposite. So from adults, we have some adults case reports, and then we have this type of data. And it's somewhere quite logical that the probiotic could prevent translocation because it got an action on the intestinal epithelial barrier, and also we know that the higher is the diversity of the gut flora, the lower is the risk of translocation. So when you look at you want to have a look at the bloodstream infection in probiotic fed infants, in preterm infants with a supplementation based on probiotics. You can look at the case reports, you can look at the randomized control trial, and you can look at the experience from the units who have been publishing their experience, and not so much, but there is some case reports, and most of the case reports occurred in immunocompromised infants post-surgery and short-cut syndromes. And it was mainly with Lactobacillus GG, but there is a published case of LGG infections in neonates who did not receive probiotics. And there is one case which has been recently published by a German team of bifidobacterial probiotic strain sepsis in the preterm infants receiving prophylactic mixture of probiotics. Then, when you go to the randomized control trial, I'm going back to the first slide to look at the RCTs. What you can see is that there is no, in this high number of infants, there is no reduction, there is no increase in, there is no reduction in late onset sepsis, but there is no increase in infection, you can see in the two-way. There is no increase in infection in infants who are receiving probiotics. The question I'm wondering is that when I went back to the papers, it's always the same thing, that when you go to the method section, then you have culture-proven sepsis has been evaluated. But you don't have, you are not sure from that aerobic and anaerobic blood culture were performed. And you all know that it's very difficult to have a 1 milliliter twice from a baby which is not doing well. And so we have to be careful about that. And to my knowledge, there is only 3 studies who look really at both aerobic and anaerobic blood culture. It's the one from Walter Mihach, who were fed, baby was fed bifidolactis. The other one was one recently published from, I think, a Mexican team, 75 virobus weight infants, a multi-strain probiotic mixture, and the other one is from Lyon in our team, in Lyon and Montpellier, where we look at, in a study, a lot of, it was 145 virobus weight, and half of them were ELBW, and it was bifidolactis against longum, and that was called Primaflow study. And what has been shown by Walter Mihach in his study, that there was no sepsis with probiotic strains. The Mexican study, it was the same. There was no sepsis with probiotic strain used, and it was a mixture of Lactobacillus bifido and Streptococcus thermophilus. And we didn't find any infection related to probiotic strains in our study, which are, here are the results of the proportion of late onset sepsis and the type of microorganism we found in our study. So then comes the experience from the teams who are using that in a routine way. And there is 2 data published, probably there is more, but I think these 2 are the main ones. One coming from Italy, from Manzoni, and the other one coming from Finland, from Turku and Luoto in 2010. And the 2 have been done in studies where in units where they are giving the LGG from the first day or very early, and once a day, and the NEC incidence in these babies was 1.9 and 4.6, and there was no LGG infections in these teams. So that's what we have to look at when we look at the infections. And the other point is the growth, because we had a study about the growth, a prospective study, because when you look at the data about growth, and you have the data from Kitajima a few years ago, showing that babies with probiotics, it was Bifidobacterium breve, improve, have a better feeding tolerance, and then they improve their body weight, their growth. And in a prospective study we published in GP in 2011, we found that the babies with a better diversity of the flora had a better digestive tolerance, and there was a relationship between diversity score at 6 weeks and the weight gain. And there are also other studies from on in antibiotic-treated infants showing a difference related to probiotics. And there is this interesting data showing that there is probably a metabolic effect, and showing that there is it was a study from Bached in 2004 with a lot of experience in mouse, and showing that when you are implementing the flora of a obese mouse, then you in a lean mouse, then it can become an obese mouse. And there is some difference in the flora of obese adults, and that's the point. And that's the point which is interesting us is the data coming from a French team from Marseille, who has been publishing the difference in growth in broiler chicks and ducks. The point is that there is a difference in weight gain, but the problem is that in this type of studies, that when you look at that, personally, I don't know what is the standard normal growth of ducks and broiler chicks. So I'm not able to see if there's a problem. Is the control group is growing slower, or is the best growth, or there is a better growth in the intervention group? It's not possible for me to say that. But what we have been doing is that we performed a randomized control study, with the main outcome was weight gain, and we were not able to find a difference in infants supplemented with different probiotics. It was bifidobacteria. There was three types, lactis, longum, and Bose, but there was no effect on growth. And then after 4 or 6 weeks supplementation, depending on gestational age at birth, there was no difference in head and head circumference, and there was no difference in growth at 31 weeks, neither in body composition. So when you look at the end, then you have on one side, you have the benefits related to the reduction, significant reduction in NEC and mortality, and on the other hand, probably sepsis related to probiotic strains. It exists, but it's exceptional. So when you look at you can see that there is some evidence demonstrating that probiotics are effective and safe when compared to other recent innovations that have become a standard of care. If you look at if you hear the data analysis from Wang in 2011, the reduction in NEC and mortality, and when you look at what happens for the antenatal steroids, inhale NO, and hypothermia for hypoxemic encephalopathy. So it seems quite, you look at the number of infants in these studies, and it's quite interesting to see that we should be able to go for this type of use for probiotics if we consider what happens in the past with other type of interventions. But it's not, as I said, not the end of the road, and we need to refine the appropriate therapeutic regimens for the probiotic use before routine use. We need for the randomized study, but with a follow-up, because we have a lot of data on short-term effects, not so much on long-term effects. But you know that it's going to take time, and even if we need that to confirm health benefits, we need to have some more data on the given strains, the better strains, because as you see, you need to evaluate for each strain or each mixture if there is a positive result, and we are lacking a good animal model for that. So we have to do clinical studies. But the thing is that I think it could be difficult in the future years to have prospective randomized controlled trials, because parents could not accept to give their consent because they don't want their infants to receive a placebo. As you know very well, the parents are more well informed, and it's a good thing. They are informed about the complication related to prematurity. They know very well that the NEC is the most dangerous one. They know very well that the probiotics could give a preventive effect. And furthermore, the difference with other therapeutics like inhale NO or things like that, or antenatal steroids, is that it's widely available. And I recommend you to go to the paper from Annie Janvier from Montreal about this question of probiotics. And in the paper, she said that some parents buy them for their preterm infants in health food stores. Some mothers have started adding probiotics to their breast milk. The medical team can either be unaware, a preterm is in fact receiving probiotic, or tacitly not interfere with these parental initiatives. So the question is that you start to have this type of behavior from the parents, And so we have to move. And if we look at that, the question of availability of probiotics appropriate for NEC prevention, because, for example, in France we have a lot of probiotics, but it's for adults, and it's very difficult to find a good probiotic for preterm infants. Then the availability is quite variable depending on the countries and the regulation. To my knowledge, in the US and in North America, FDA doesn't want the use of probiotics in preterm infants. Then we can summarize that when available, probably being enrolled in a randomized trial should not be the only way for a baby to get probiotics. Parents should be fully informed, and a clear description of reduced NEC and mortality and lack of adverse events in RCTs should be discussed with them. When it's not available, then we have to go to the regulating authorities to explain the benefits-risk ratio and to support further studies to refine probiotic regimen, as we said. So I think that sometimes being late may have great consequences. And it can be the case for some futilities like being first on the moon, but it's very important that we are taking care of the babies, much important. So thank you for your attention.